Yes, we can see your slides.
Okay, perfect. In a full screen, right?
Yes, there are just numbers at the left side, but it's okay.
Okay, it's okay. So, hi everyone. I'm a clinical psychologist who is making private practice and also doing research in the field of psychodermatology in Turkey. So, in this presentation, I will try to integrate some of the approaches about primitive intrapsychic structures, psychosomatics, and physical illness that might have underlying developmental factors, and try to link physical illness with the view of developmental psychopathology. Also, I will discuss what might be considered when we are working with medical and psychosomatic patients who might have early maternal trauma. I will only focus on the maternal trauma in the early period of life, not other types of trauma. So, as we know that there is no single factor that triggers many disease. Both environmental and systemic factors may cause the emergence and exacerbation of the disease in individuals with genetic predisposition. The relationship between maternal traumas and physical illness has been researched and discussed in recent years. Also, we see that the biopsychosocial model was taken into consideration for understanding this physical disease and psychological disorders. I put this scheme here because all the things I will be discussing today will be based on this model. I'm not asserting that all of these illnesses just happen because of the mother. I just will discuss how the mother's function interact with the other biopsychosocial factors. So in the biopsychosocial model, we have seen that caregivers are crucial for infants' body-mind-brain system. By the way, I love this term, the birth of the self from the other. I think it gives it highlights the most importance of the mother. So when we look at the role of caregiver, we see that interpersonal neurobiology, infant research, affective neuroscience, developmental psychology, and relational psychoanalysis agree on the fact that the individuals develop as a complex body-mind-brain system in the intersubjective dynamic process, first with primary caregiver, who is generally the mother, and subsequently as a triadic one with both caregivers determinant for the future development of the child. According to these fields, early relational trauma and lack of secure base causes significant deterioration in endogenous stress-sensitive hormones and cortisol production and negatively affects neurobiological development. And studies show that the traumatic stressor in childhood, emotion dysregulation, insecure attachment style, and separation individuation difficulties adversely affects emotional, relational, and cognitive development and increases susceptibility to physical and mental illnesses. Also, by the many theorists, it is concluded that the mother's function play a significant role in the child's development. I put here a figure. This figure shows Cassidy and her colleagues' secure-based model that was proposed by Bowlby to understand diseases. They modified it. Cassidy offers a model in which insecure attachment correlates with immune system disease and the hypothalamic pituitary adrenal, means as HPA axis, with level of inflammation in the body, so that several organs might become the designated target in combination with vulnerability in the family. So in this figure, this lack of secure base affect cognitive and affective mechanisms, which is important for personality and self-other representation, especially I will discuss it with a psychoanalytic point of view. And these cognitive and affective mechanisms affect stress response with an activation of autonomous nervous system. Right now, I have that. And then this increases the risk of developing disease. So, by the lack of secure base, Cassidy means that the child cannot go to a parent when he or she experiences a difficulty. For example, as a result of absence of maternal function or problematic environment that he or she is exposed. Then this lack of insecure base affect the cognitive and affective levels of the child. Normally, by the help of a caregiver in the secure environment, the brain system puts together the representation of self with the representation of the self with the other, and the affect connecting them, so that the various representation of self and other in a dyad are linked by an affect, according to Kernberg. For psychoanalysis, the mental representation of self and other in the forms of object relation is fundamental in the development of the self and of personality. Short defines them as mentally stored representation of the self directing affect toward an emotionally significant external object, in which cognitive and affective processes are linked. This means that the cognitive and affective mechanism can only be linked if there's an emotionally significant object. So in here, mother's function, emotion regulation abilities, and her maybe own psychopathology became important, since all of them directly affects the child's cognitive and affective mechanisms, also interoceptive mechanisms. Also, these self and other images seem to be represented in the right hemisphere and seem to mature around 18th month of age with the help of a caregiver. And then these cognitive and non-cognitive mechanisms activate the stress response with the activation of autonomous nervous system, as I said, which might produce inflammation in the body with an increase in the level of C-reactive protein. These high levels of C-reactive protein present the risk that a target organ through vulnerability in the family might be attacked. So it is shown that problems in early relationship with the primary caregiver may cause many biopsychosocial problems in the child. As I've said, this cognitive and affective mechanism affect bodily system, and they are mainly affected by the intersubjective experience with the mother in the first years of life. So in this situation, the relationship with the caregiver and the function of a caregiver on infant's life have become important. Then, what we know about the function of a mother, we could suggest that caregiver has an importance for the infant's mind-body integration. According to him, many physical and psychological problems may occur as a result of the inadequacy of the mother's function when the integration between the psyche and the body does not yet exist. So if you make a quick summary of many theories about the mother's function, by the way, it is almost impossible to make a review about it. Almost all of them are synonym at the end when we look from the big picture. So it can be said that the function of containment, holding, mirroring, emotion regulation, individuation, libidinal availability, intersensoriality, being a self-object, transitional object, auxiliary ego, alpha function, or I added right now reflective function, or synchronization between them, attunement in the ongoing relationship between caregiver and the infant, seem to be important factors for a child to grow up psychodevelopmentally healthy. Through these functions, a child can separate from the object, means that develop a different and separate self-representation from its mother, and then became individuated, means that forming a unique and continuous sense of self. Also, through the mother's function, the baby learns how to regulate his or her own emotion. But of course, in here again, the mother should have the ability of regulating her own emotion to perform these functions first. But what happens if the mother is unable to perform these functions? For the baby, the external object cannot be projected inward. There is an increase in the baby's fragmentation feelings. The ego strength remains weak. It causes an increase in dependency and separation problems, increase in primitive and dissociative defensive operations. And also mind-body-brain system is affected, such as poor connectivity between the orbitofrontal cortex and the amygdala, or misshapes early developing right lateralized cortical subcortical systems. So, according to many theorists, mother's function play a decisive role in the development of the child's intrapsychic structure in order for the child to create self and other representation. If these functions of the mother are unpredictable, unstable, worrisome, hostile, or maybe she performs all the functions but not libidinally there, the individuating child cannot develop a reliable frame of mind to regulate his own emotions, and he may remain in a more primitive state. As a result of this primitive state of mind, the pathological persistence of primitive defenses increases. They fail to develop integrated sense of self. Over-dependence on external object increases. Inconsistent personality traits develop due to unstable self-states in interaction with others. So eventually, all manifestations of functional deficits of the early developing right body-mind-brain has a great impact on self-integration. As Kernberg argues that predominantly using of primitive defenses, problems in early object relations, and the separation individuation difficulties indicate a more primitive personality organizations. Those traits seem to reflect identity diffusion, which is the first element to be considered in diagnosing a borderline personality organization. So if we review somatizations from a developmental psychopathological view, we see that some theoreticians read psychosomatic problems as consequences of the representation of an internalized negative self that encloses an introjected representation of bad object, an aggressor, or an internal persecutor. Some of them consider psychosomatic disorder to be one of the outcomes of the problematic junction between mind and body. And several others also consider psychosomatic disorder to be part of the pathology of personality disorders. However, when we put all of these views together, they give us important perspective about primitive intrapsychic structures, somatizations, and other physical illness that may have psychodevelopmental root, I guess. So I guess we do not need to take a side, rather we should consider all these theories when we are formulating these patients, and this is what I'm trying to do right now. So I put an example to show the field of psychoneuroimmunology's view on the most important elements involving the psychopathogenesis of disease. I love this scheme because when I solve this scheme, I see the secure attachment, and I was so happy. So I put it in here. In this figure, what we see, beside from genetic predispositions, there are factors related to early childhood issues that affect the gene activation. You can see that many biopsychosocial factors were considered, but even if there is no error between the attachment style and resiliency, I can't see because there's me in the screen, but attachment style, resiliency, self-efficacy, and social support. Some studies even show that attachment style have a relationship with these factors too. I've shown this figure because we as an integrative psychotherapist may work with these patients interdisciplinary, especially with the disease which are closely related to developmental factors such as insecure attachment style that's seen in this figure, and we should expand our field by working these patients rather than excluding them from our field of study or field of practice. I wanted to give another example of a disease that psychodevelopmental factors are involved. I made my thesis of research with psoriatic patients, which has psychoneuroimmunological pathogenesis. In the literature, it's shown that mostly seen psychological factors that are related to maternal trauma in psoriatic patients were perceived maternal rejection, emotional dysregulation, alexithymia, insecure attachment style, separation individuation difficulties, lack of symbolic thinking, and predominantly using of primitive defenses. As you see, when all these factors come together, it can be said that these patients may have mind-brain-body disintegration and may have primitive personality organization, as I mentioned before, like what Kernberg said. Of course, the causal relationship and etiological discussions remain open in this virgin field and research. However, this interdisciplinary point of view helped me to understand these patients better, which I will be explaining in the following slides. I have time, right? Yeah. Okay, besides from the quantitative findings, I made some off-the-record observation on these patients in the interviews. It was so clear that these patients have identity diffusion and mind-body-brain integration problems. They seem to me that they have a lack of symbolic thinking, have discrepancies and disconnections between their thought and affects, have problems in understanding and explaining their interoceptive, affective, and cognitive changes, and have instability between being hypersensitive to external stressors and object and denial of the stressors and object, and have over-dependence or again denial of the object. When we put all of these data together, we have seen that these patients are more likely to function in a borderline personality organization. It's just a thing that we should consider. So based on these findings, my observation and the literature review that I've done, I suggest that when you're formulating and prognosing patients who have physical illness, especially if it is highly stress reactive, should be taken into consideration for their level of personality organization and mind-body-brain system integration. As I've seen, only an intervention on the structure and a change in the underlying personality disorder means that resolving affect dysregulation can resolve the symptomatology. Since almost all of the patients came to clinic with exacerbation in when they are stressed, so it seems that they have some structural problem rather than symptomatologic. Of course, symptomatology is a problem, but we should consider the underlying mechanisms. So according to Murci, symptoms are to be understood as peculiar body-mind-brain expression of affect that have overcome the threshold of stress and are therefore released as a form of affect dysregulation, striking to Soma. So, yeah, I'm here. Also, their level of personality organization seems to be important, since patients who have the most severe personality disorders are connected to the most severe and the earliest intersubjective traumatic relationship and have no or minimum symbolic representations. It is especially important for differential diagnosis and therapeutic interventions, as we have seen that neurotic patients have symbolic representation ability at least better than the borderline patients, and mostly have less severe traumas than the borderline patients. It's not a strict criteria, by the way, it's a smooth understanding. To understand it, we should check whether there is identity diffusion and check the type of defenses used from primitive to healthy, and we should check quality of object relations, their conflicts, intrapsychic or interpersonal, interpsychic conflicts, and we should check their separation individuation, especially the anxieties of separation individuation, such as fear of abandonment, engulfment, fusion, etc. Also, we have to consider that the level of personality organization and level of emotion dysregulation may affect the prognosis. And lastly, of course, transparency and counter-transparency are important. Yeah, according to the review that I've done in this field of, especially the field of neuropsychoanalysis and the other related fields that I've mentioned today, I will provide some of the therapeutic goals in the sessions while working with these patients. The mind-body-brain integration and the integration of identity should be the goal in therapy, since all of these disturbances in these systems are chaotically affecting each other. Of course, first, the level of personality organization, whether they're neurotic or borderline level, and the level of mind-body-brain connection with an emphasis on emotion dysregulation should be understood. Also, the intervention that is done by the mental health professionals should be target the structure, not the symptom, since most of the patients use medical treatments that target their symptom. Also in Turkey, I have worked with these patients in the hospital with an interdisciplinary team. We were a couple of dermatologists, psychiatrists, and clinical psychologists. So based on my experience and the literature, it can be suggested that the hospitals might be an appropriate place to work with these patients as a team. Now I see and suggest that physical illness, especially if it is highly stress reactive, should be consulted by the practitioner to the mental health professionals for working collaboratively in order to intervene better and decrease the relapse rate. Based on my experience, they taught me a lot of things, and I add many things to them. So Lastly, the mental health care professionals should be taught on mind-body-brain system and identity diffusion and other components such as pathogenesis or etiology of the illness. Lastly, in this field, there are some etiological and basic research in the literature, but controlled and applied research are so limited, so that more research should be done in the field of Psyche-Soma interaction in order to expand our field first before the clinical practice. Yeah, that's all I have. Thank you.
Thank you, Ece.